everyone for attending. It sounds like you're a great group. I'd love to find out more about the work that you do, maybe at the end. So yeah, as Selena was saying, I'm a doctoral researcher at UCL in London, and I'm also a research associate at Barts Health NHS Trust. As Selena said, it's my first talk in over a year, so be kind with me. I hope I don't and too much. And if there are any particular questions that happen throughout the presentation, feel free to shout out. I'm keener for you to do that than to go with misinformation all the way to the end. So clinically, I have a background in pain management physiotherapy and a bit of pelvic health as well. And before I begin, I'm going to acknowledge my funders, the ESRC and BBSRC. Without their support, I wouldn't be here today to talk about chronic pain and the perimenopause. So I'm going to set the scene a little bit with a few definitions so that we're all on the same page. And if you know these things already, just think about something else for a moment. So menopause is when our periods stop, but it's an event described a posteriori. So we don't know when our last period is until it hasn't happened for a while. So 12 months is the cutoff point at which you know that your final menstrual period was indeed your final menstrual period, and at that 12-month point you have menopause. The average age in the UK is between 45 and 55 years, but the perimenopause, so the symptomatic part of menopause, is the part before the final menstrual period and up to 1 year after, so up to the menopause itself. It can last up to 10 years, and for some people even more. The symptoms that are experienced during this process are varied. There are menstrual symptoms like increased period pain and menorrhagia, so more bleeding. Mental health symptoms, depression, anxiety, irritability, tearfulness, etc. Vasomotor symptoms, which are probably the most well-known menopause symptoms, hot flushes, night sweats. Sleep disturbances and urogynecological symptoms. So those would include your stress and urge incontinence, vaginal dryness, difficulty with intercourse, etc. And then pain, headaches, muscle pains, joint pains. So you see a lot of these symptoms overlap with presentations that people with chronic pain might also be experiencing, whether they're having perimenopause or not, whereas some are particular to menopause. I'd also like you to think for a moment about that time span of the perimenopause, and if someone is having their menopause at 45, that means that people coming in your clinics in their 30s might already be perimenopausal, even if hormone markers aren't there yet to prove it. So the next slide is about perimenopause and musculoskeletal pain. These are a few things that happen physiologically with shifts in hormone levels. So estrogen drop-in affects connective tissue. So articular cartilage, subchondral bone, ligaments, tendons, and synovium become less elastic. So if you think about your recurring or chronic tendinopathy patients, this might be a concurrent instigator. Inflammation. Estrogen is an anti-inflammatory and also a mild immunosuppressive. So if you think about the rise of rheumatological disease and also just low-level inflammation and the effect that it can have in a clinical population, perhaps the most well-known effect of estrogen is its role in bone density. So bone density starts dropping with estrogen decrease, and that leads to osteoporosis and secondary pain from there. And sex hormones also have a role in pain down regulation. So once they start dropping, pain isn't managed as effectively from a nervous system perspective. So although this is not a slide about chronic pain, you can see pathways for chronicity emerging from these physiological mechanisms. So my interest in this topic, the intersection of chronic pain and perimenopause, obviously came from working as a physiotherapist in the NHS, and I was working both in the pelvic health service and the chronic pain, the pain management service, and I started noticing overlaps in terms of the population, the symptoms, etc. So yeah, clinically we know that there are overlaps between the symptoms, but I guess back then I was interested in trying to understand if there was a chicken and egg dynamic going on between the two, if one led to the other. For example, in the literature, there's a lot of speculation whether fibromyalgia might be a perimenopausal manifestation for some women. I was interested in these kind of questions, but there are obviously various layers on top of this. So people are complicated, and there are narratives that happen throughout the life course, which contribute to both the experience of pain and menopause. So if we think about gynecological histories, social factors, these are all things that affect experiences of pain and menopause. So from very causal and interventional questions, I moved on to more observational questions that relied on mixed methods approach to try and unentangle a few of the issues at stake. I'm going to move on to talking a little bit about the existing literature around chronic pain and menopause. And it's not going to take very long, because when I first did a scoping review in early 2024, there were only 197 records that showed up, and only 76 were pertinent. I'm sorry that the graphs are probably a little bit small, but the bar chart at the top is showing frequency of publishing on the topic from early days right to nowadays left. So there's definitely a raise in interest in the topic, but most of the articles are still prevalently within the gynecological kind of journals, and the types of articles that are being published are literature reviews, but not systematic. A lot of opinion pieces and commentaries, few observational studies, and very small number of interventional studies, but again quite small and of very varied quality. I would also like to note that the definition of menopause that studies use is very inconsistent, doesn't follow necessarily the international guidelines, so it's difficult to compare and make sense of the literature available. But I'm going to talk about two main areas in the publication. One is around pain and perimenopause symptoms, and I'll draw your attention to a study by Gibson et al. In 2019, and she published a couple of articles on this topic. Her work shows that women with menopause symptoms had nearly twofold the odds of having chronic pain. So some people are very lucky and surf through the menopause without knowing that it's happening, so no symptoms at all, and that's great. But this study that was on an American sample of female veterans showed that if they did have bothersome menopause symptoms, they also were more likely to have chronic pain. Now, from an intervention perspective, what I gleaned from this initial scoping review is that the interventions proposed are quite varied. So we've got we've got things like exercise, alternative therapies, etc., and a little bit of literature around hormone therapy as well. And hormone therapy is difficult because in the studies up to now, the samples are very small and the results are inconclusive. And when we look at the association of hormone therapy with chronic pain, perhaps from an observational level, it can be really misleading because there seems to be actually a positive association between chronic pain and hormone therapy, but hormones might have been prescribed for other reasons or to actually improve the pain, so it's not causal. Because of the relative paucity of information around even just the general insights around chronic pain and menopause, as I was saying earlier, I took a step back and started working from an observational perspective. So I'm going to present today two studies. One is a quantitative study, which I'll describe now, and another is a qualitative study. This is part of a larger PhD where I investigated other things like cultural differences, etc. But this is really an introduction just to tell you a little bit about what happens at a population level, and then some patient narratives or participant narratives to integrate that. So this first study is a recent study that I did on a population representative sample, which aimed at identifying pain and perimenopause symptom trends in the general population. And for it, we used data from the National Child Development Study, which is a birth cohort study of people born in the UK during 1 week in March 1958, and for whom we have very strong longitudinal data. The sample I used was of 4,303 females, for whom we had outcomes around the presence of chronic regional pain and chronic widespread pain at age 44, and who'd also answered a menopause questionnaire at age 50. Chronic pain was defined by participants answering affirmatively to whether they had pain lasting for 3 months or more, and then it was categorized as regional or widespread using the American College of Rheumatology definition of fibromyalgia and looking at a body chart for locations. Out of our sample, by age 50, 25% reported, according to our measures, to be premenopausal, 43% were perimenopausal, 27% were postmenopausal, and about 5% had had surgical menopause. So let's look at the data observationally, descriptively. As we expected, we noted that some symptoms like sleep problems or psychological issues can be related to both chronic pain or menopause, but were higher in chronic pain categories. So if we look at the top, the row with sleep, in the chronic pain graph, we've got about 50-50 of people who have sleep problems and don't have sleep problems. Whereas if we look at people with chronic pain, we've got a majority with sleep problems and a minority who do not have sleep problems, which I think we can see match within clinical populations. Same goes for anxiety and depression. So these are symptoms that are already quite common within a chronic pain population. But we also noted that other symptoms like vasomotor symptoms, which are traditionally more menopause related, and urogynecological issues were also more prevalent in the chronic pain population. Yeah, you can see for yourselves. So this led us to ask how these symptoms, all these menopause symptoms, clustered. and how they present within our sample, or better, if there were particular groupings of menopause symptoms which could tell us about different experiences of menopause for the women who participated in this study, regardless of chronic pain, and then having a look at how chronic pain relates to that in a second moment. So as I said, some women might have no symptoms at all. Some people might find it a little bit troublesome, and some people have a dreadful time. So it was trying to identify these groups within the data. To answer these questions, we ran a latent class analysis, which is a statistical technique which identifies underlying unifying traits within a population. So it does exactly what we wanted it to do. And we ran this on the sample, taking into consideration 19 menopause symptoms from the questionnaire at age 50. And the results showed us 4 classes or 4 groups of experiences of menopause, which I'll describe now. The first class or group represents the least problematic menopause experience from a symptom perspective, in which participants are united by having relatively low probability of most of the symptoms. Some, of course, higher than others. Aches, hot flushes, urinary incontinence, and sleep problems seem to be the ones that peak a little bit here. But again, the probabilities are, well, about 30% for pain and much lower for the others. So an uncomplicated menopause. The second class or group is dominated by vasomotor symptoms with concomitant moderate sleep issues, aches, which are ubiquitous throughout the classes, and also some psychological symptoms. The probability of the other symptoms remains really low, and definitely this group is marked by vasomotor symptoms, which are 80% or higher. The third class is a menopause experience characterized by psychological problems. So all these symptoms at the right, as well as sleep issues and aches. So the psychological problems in the questionnaire were irritability, anxiety and depression, tearfulness, panic, and forgetfulness. And most of these the probability is above 60%. The final class or group shows us possibly the worst menopause experience, where the margins for all symptoms are really high. So you see a lot of symptoms above the 80% mark. So we have all the somatic symptoms, the sleep and emotional symptoms, the urogyne symptoms. Everything is flared. So this is the worst case scenario. And you see that these groupings help us understand much better different menopause profiles that subgroups in the populations might have. So we then moved to looking at how these groups related to chronic pain. So for the participants that didn't have chronic pain, this is how they were distributed according to the different classes. The top is the first class, unproblematic. The second is a vasomotor class. Third is a psychological class. And the fourth is the high menopause symptom group. And you see that this population is less likely to have a bad menopause experience compared to a good menopause experience. But this reverses when we look at the chronic pain population. So people are more likely, 30+% of the population are actually in the high menopause symptom group, with only a minority really experiencing few bothersome symptoms. And we repeated this to look at chronic widespread pain. And this accentuated really the picture. So almost 50% of people with chronic widespread pain are going to be part of that high menopause symptom group. And we know that some of these symptoms are already features of chronic pain, but we're also talking about urogynecological symptoms and vasomotor symptoms, which can be quite bothersome themselves. So what are the insights really for us here? Well, that females with a history of chronic pain are more likely to experience a wide range of bothersome symptoms associated with the menopause. And it leaves us with a few questions. Does optimal management of menopause symptoms improve patient burden? You'd think yes, but we don't know. There's no research to back this. And what does optimal management look like anyway for individuals? And this is something we don't yet know. There are groups that are looking at perimenopause management in general, regardless of pain, and trying to look beyond hormone therapy at more holistic exercise-based management. But this is hopefully something that I will answer in a postdoc when I get there. Last study is about the patient voices and how they fit into the picture. So I'm going to talk about a qualitative study that I did around chronic pain and perimenopause. This was an ethnographic study, so an in-depth and multimodal qualitative study ran over time, where we had 20 female participants aged between 40 and 65 who were interviewed on 3 separate occasions to explore their gynecological histories, their social histories, experiences of pain, menopause, the way they navigate life, their healthcare experiences. We did some go-along interviews in which they chose an activity to do. Some chose to cook a meal or go to the gym, and we talked about how pain and menopause symptoms affect them during these activities. And a subsample of 5 women we then saw for further meetings over the course of another 4 months. The transcripts of all the interviews were then analyzed thematically and fitted to an inactive framework, which really shaped the methodology for the project. So our participants had the following characteristics. Most had chronic widespread pain, and of those with regional chronic pain, it was often in more than one joint, but not widespread. And others had pain migrate from joint to joint across the years, especially across the perimenopause years. So it was not straightforward regional pain either. It's also notable that around half of the participants had the onset of chronic pain prior to the perimenopause, so premenopause. However, most of them reported their symptoms worsening during the perimenopause, and if not their pain per se, it was their pain management that worsened. In terms of symptoms, most complained of some form of psychological symptom like low mood, being tearful or irritable, as well as a variety of other problems. Notably, vasomotor symptoms were described as problematic only by a minority. And a key symptom they described in association with the perimenopause was fatigue, which was not included in the data set that we used for the latent class analysis, but we know being extremely relevant for pain patients. So in terms of allocating the participants to the classes we just talked about, only about 15% were in the mild or vasomotor dominant symptom group. 25% were in the psychological distress group, and 60% were in the high impact of menopause symptoms group, which distributes quite well on the charts we saw in the last few slides of the previous study presentation. We're still analyzing the wealth of data really produced by this ethnographic study. So I'm going to limit myself to talk about a few insights that might be relevant or pertinent for you. The first is about symptom confusion. Overall, when speaking about their pain and perimenopause experiences, participants reported struggling to qualify the relationship between symptoms. So a common example was that triangular relationship between poor sleep, pain, and irritability. So where pain and sleep, they have a circular relationship, don't they? And one triggers the other, but then having an impact on mood during the waking hours and not really knowing what was the triggering cause was a cause of concern to these participants. And to bring it to the pain and menopause intersection, a common sentence from participants was, is it my pain that's causing this, or is it the menopause? Signifying that difficulty in meaning making and also the kind of answers that people are after, and not knowing basically what value to assign to pain. Is it is it dangerous pain, or is it just menopause pain? Was often something that people were worried about. It's also a difficult period in life compared to other periods which are defined by pain which can be ascribed to physiological problems that are or processes that are better understood in a woman's life, like menarche, menstruation, pregnancy, etc. Where pain has a specific etiology or rationale, or people would say role. So while for some pain was a feature of the perimenopause, whether it was interpreted by them as a perimenopausal symptom or not, this really varied. And the majority of perimenopausal the majority of the perimenopause experiences really seem to act as an amplifier to something that was already there, making it harder to manage existing pain or the overall menopause experience. The second insight regards healthcare experiences and the difficulty navigating various services and integrating pain and perimenopause care. I liked this quote from one participant who went to her GP to talk about perimenopause management, but also this widespread chronic pain which had ended up being rheumatoid arthritis. And a distressed GP said, I don't know what women are expecting nowadays. Of course, it's not going to be like walking in daisies. So it's a sentence that really speaks perhaps to how menopause symptoms are seen as normal by clinicians to be dismissed, and also the exasperation of seeing yet another woman who's struggling, who has a complex and unique presentation and can't really be pinpointed. And I think healthcare professionals have a hard time considering that education around menopause and female physiology in general is quite poor. So in terms of the healthcare experiences themselves, participants reported a continuum with this idea of symptom confusion and the difficulties navigating services, because pain and menopause were treated separately. And this was very common for people with rheumatological conditions, where there was an additional confusion of the side effects produced by the medications that they were taking for, say, rheumatoid arthritis, which were just additional symptoms. So not knowing what was a side effect, what was perimenopause, what was rheumatoid arthritis, was really difficult to navigate for them. And also knowing that once your main symptom has been ascribed to a professional group it's very hard to get care for the other things. So if they were under rheumatology, they found it really difficult to then access gynecology or HRT review. The third and fourth insights are somewhat contradicting in that they juxtapose a sense of resignment. Oh, I have pain, I have menopause, just get on with it. So a kind of attitude towards pain or ill health. Whereas the fourth one is more active. It's like, why should I put up with this? It's not normal, and it talks a little bit about mistrust and mismanagement. Now, they're not mutually exclusive. While the changes in pain experience brought up by the perimenopause are the source of systemic change for some participants, and by systemic, I mean beyond the body, I mean within their lives, some people change or cut their jobs, cut their hours, redefine their priorities around the house in a quest to really manage their symptoms and pace. There's also a sense of just having to get on with it. And this is it's nothing new. It's a learned behavior towards pain that people were talking about. They were talking about gynecological experiences across the life course. They were talking about very painful periods that they just had to put up with, and this just being the nth thing that they had to push through. So interestingly, a high proportion of participants in this study had dysmenorrhea, which they would sit out and not allow impact their daily lives, which is, again, a learned attitude to pain. One participant reported that their health professional had commented more than once that she didn't appear to be in very much pain, to which she commented that the thing is, pain or no pain, somebody has to fold the laundry. So again, it's about this management of pain and ill health that is probably counter what people in pain management clinics try to teach their patients, but is a very social phenomenon. So these experiences of pain and symptoms being questioned or discredited really affect people and how they understand their pain, which then has an impact on how people might participate in interventions. So I think I probably finished on a bit of a funny note, but moving on to insights. Chronic pain during the perimenopause is difficult to navigate. Approaches to self-management are influenced by gynecological histories and healthcare histories, and I think this is something we need to keep in mind when working clinically. And joining the dots and lessening the burdens for patients seems to be what is key for them. So someone who is able to look at both phenomena and make sense of them, and also making sure that there is perimenopause awareness throughout different disciplines and that services are joined up. So that is me for today. I'm doing a lot of impact work around education in clinical settings around these topics. So if anyone is interested in taking part or delivering something at their site, that would be great. Please get in touch. And yeah, if you have any questions, I'd love to hear them.